Today we'll be discussing Mr. MP, who presented to the emergency department on April the 20th with complaints of chest pain, shortness of breath, and dizziness for one day. He was diagnosed with acute coronary syndrome. The patient is a 59-year-old male who is currently employed as a carpenter, is married, and lives in Colleen, Louisiana. History of the present illness includes complaints of chest pain, dizziness, and shortness of breath for one day. He describes it as heaviness that radiates to his left shoulder. He reports becoming short of breath and diaphoretic. He states the pain comes about at rest and with exertion, and he also reports dizziness. He states the pain is relieved with aspirin. He denies any history of bilateral lower extremity edema. Patient does have a history of coronary artery stenting per Dr. Keimel in July of 2016. Patient states that he is compliant with his medications and diet, although he continues to smoke cigarettes and marijuana. Has a past medical history of coronary artery disease, hyperlipidemia, GERD, and hypertension. He has no known drug allergies. His current medications are Lipitor, Aleve, Plavix, Lopressor, aspirin, Pepcid, and Wellbutrin. He has a family history of heart disease. Social history includes smoking 5 cigarettes per day, occasionally using marijuana. He denies alcohol use or any other illicit or prescription drug use besides the marijuana on occasions. Review of symptoms is positive for generalized weakness, dyspnea on exertion, shortness of breath, chest pain, and dizziness and weakness. Vital signs were 130/71. While lying, he had a heart rate of 63. Respirations were 18. They were even and unlabored. Temperature of 97.6. Pulse oximetry of 98% on room air. He was 71 inches tall. He weighed 151 pounds. Physical exam revealed a chronically ill-appearing male. Skin was normal for ethnicity. It was warm. It was dry, with no rashes or lesions. Head, eyes were atraumatic. Normal cephalic, pearl, EOMI. Ears, nose, and throat were atraumatic. Airway was patent. Mucous membranes were moist. Pharynx within normal limits. The neck was supple with full range of motion. Lungs were atraumatic. Symmetrical chest expansion. The trachea was midline. Breath sounds were clear to auscultation. Heart rate was within normal limits with a regular rate and rhythm. Abdomen was round, soft, and non-tender, non-distended, with bowel sounds present. Upper extremity inspection normal. Full range of motion. Lower extremities, no edema, baseline, lower extremity weakness noted. Pedal pulses palpable +1. Neurological exam, awake alert oriented ×3 with normal speech. The lab data was negative for any acute processes, as well as the chest x-ray. There was no active pulmonary findings. Cardiac markers as well as EKG were negative as well. 3 main stressors that Mr. MP was experiencing was health impairments, financial concerns, and job requirements. The health impairment is an intrapersonal stressor that affects the patient's physiological system. Mr. MP was the sole provider for his family, so this was an interpersonal stressor for him that was affecting his psychological system. His job requirements and job demand, he stated that he felt like he was slowing the crew down, having to slow down due to his symptoms. This is an extrapersonal stressor, and this was affecting the patient's psychological system as well. The flexible line of defense and the normal line of defense are disrupted as evidenced by the patient moving from a wellness state to a state of illness. Differential diagnosis for acute coronary syndrome include acute pericarditis. This is the inflammation of the pericardium characterized by chest pain, a pericardial friction rub, and serial EKG changes. The second differential diagnosis is anxiety disorders, and this is displayed as physical symptoms relating to anxiety, and this can present as chest pain, shortness of breath. Aortic stenosis is the third differential diagnosis, and this is caused by the obstruction of blood flow across the aortic valve. The classical triad of symptoms are chest pain, paroxysmal nocturnal dyspnea, orthopnea, DOE, shortness of breath, and syncope. Primary nurse practitioner interventions would include dietary counseling and smoking cessation. Secondary interventions for Mr. MP including stabilizing the patient's condition, relieving ischemic pain with IV morphine, oxygen, aspirin, sublingual or IV nitroglycerin, and Plavix, administering antithrombotic therapy to reduce the myocardial damage. Other medications to consider would be calcium channel blockers, ACEs or ORBs, and other anti-ischemic therapies such as Renexian isosorbide. Tertiary prevention would include regular visits with the patient's primary care provider and with the patient's cardiologist. The role competencies displayed in this case study include expert coaching and guidance through dietary counseling and smoking cessation, consulting with the patient's cardiologist for further cardiovascular studies, and research skills as evidenced by clinical interventions / practice that is compliant with current clinical guidelines. Current guidelines for the management of acute coronary syndrome include nitrates. Nitrates cause coronary vasodilation, which increases collateral blood flow. Beta blockers reduce oxygen demand and ventricular wall tension. Aspirin inhibits platelet function. Plavix inhibits platelet aggregation, and low molecular weight heparin decreases the myocardial damage. Then the client outcomes or goals for Mr. MP would be to educate the patient on preventing and decreasing stressors. This may also help with his smoking as well. We're going to provide the patient and family with resources, financial resources, as well as help with smoking cessation. We're going to involve the patient and his family in the treatment plans, and we're going to attain and maintain wellness. That is our goals. The follow-up plan includes following up with the primary care provider in 4 weeks and following up with a cardiologist in 1 week. If the patient continues to experience symptoms, we are definitely encourage them to call their cardiologist or return to the emergency room. And that's it. Thank you.